Okay.
So good evening once again. I'm Dr. GYAWU OSEI, pediatric resident at Konkwanochi Teaching Hospital, and this evening want to have an overview of childhood cancers. As we all know, September is a month that has been set aside to talk about childhood cancers, create the awareness and advocate for its early detection and also its management. So this evening, our objective is to get to know what childhood cancers are, to understand the causes of childhood cancers. Because, I mean, when we talk about cancers, we all think that what brings about this in children. And also we have general principles of diagnosing childhood cancer, supportive care for these children, and some side effects of treatment, which also affects their survival. Our discussion will take this outline of, we'll see a brief introduction, some epidemiology, definition, etiology, clinical presentation, the principles of evaluation of childhood cancers, management, and we'll have a look at some common oncology emergencies that may present to our facilities. So childhood cancers are relatively uncommon, but it accounts for a high number of our disease-related deaths among children. Usually when we take cases that present to us, we have less than 1% of our admissions being due to cancers. The survival rate for childhood cancers for a 5-year period, it's very high in high-income countries like the US, Canada, but for low and middle-income countries like Ghana, our 5-year survival rates are very low. And this is accounted for by delayed presentation, delayed not getting access to care, also death from toxicity from treatment, and also our high cases of relapse. So all this account for our low survival rates in our part of the region. And the purpose of this overview this evening is to help curb some of these avoidable deaths like delayed diagnosis and delayed presentation, because these children will first present to our peripheral centers where we'll be the first point of contact to see. So if we don't have a high index of suspicion to pick up some of these cancers and refer early, they'll present late and would have a poor prognosis. Globally, childhood cancers are estimated to be about 400,000 persons in a year who are diagnosed each year. And it commonly affects males. There hasn't been enough reason to back why these cancers affect males, but from research, we know that most cancers affect males than females. And the common cancer in childhood is acute leukemias. The top cancers we find in children are acute leukemias, lymphomas, brain tumors, Wilms tumor, but the commonest is acute leukemia. When you come to Konkwanochi, which is one of the cancer treatment sites in Ghana, we have new cases of about 120 to 140 each year. And as stated, corresponding to the global figures, we also have more males presenting to our facility with cancers. But unfortunately, most of our cases come in an advanced disease where there's metastasis of the cancer to other organs and it's difficult achieving cure. So these children have poor prognosis and most of them have a higher mortality. So this graph shows the common cancers we see at KATH. As stated, we have leukemia being the highest, then followed by lymphoma, Wilms tumor, retinoblastoma, and brain tumors. Those are the 5 common cancers we see at Konkwanochi. So cancers, what are they? Cancer is an abnormal growth of cell So as we all know, when we were born, we were smaller in size, but we noticed that currently we are all big. And this is due to cell division and growth that is constantly happening. However, the body has a mechanism that controls cell growth, such that when we look at this diagram, for normal cell division, the cell divides, and if there is any damage to the cell or any mutation that is abnormal, there are some genes in the cell that will switch off cell division. So normal. But if reparable, then the cell goes on to apoptosis. That's the cell lies and dies. However, for cancer cell divisions, these mutations occur and abnormal cells are formed. And the check mechanism that's supposed to regulate these cells are no more in place. What we call the tumor suppressor genes. These are genes that are supposed turn off functions, and therefore there's unchecked cell growth of these abnormal cells, and that results in cancer. And cancers affects any part of the body. So the classification of cancers is usually based on where it's originating from. So we have lymphomas, where these are cancers that originate from the lymph nodes and the lymphatic system and immune system. Then you have leukemia, that's cancer of the blood. So it begins with a bone marrow, where these blood stem cells are produced and they accumulate in the bloodstream. Then you can have sarcomas, that's cancers of the soft tissue, adenomas, where these are cancers that affect glands, like the thyroid and the adrenal gland. Moving on, we want to look at the causes of cancer. For majority of the case, we do not know the cause. So we term it as idiopathic, but research has proven that there's an interaction between the host genetic makeup and also the environment. So these two come together to predispose a person or increase the person's risk of getting a particular type of cancer. So about 10 to 15% of the cases, we inherit these abnormal genes from parents. So cancers are inherited in about 10 to 15% of the cases, but majority of them is an interplay of the genetic susceptibility and also environmental factors, which we'll look at in the subsequent slides. Also, there are some tumors that are related to age. So we realize that there are certain age groups, like we know that some tumors, especially retinoblastoma, which is a cancer of the eye, and neuroblastoma, the cancer of nerve cells. It's usually common in younger children. Usually they have a peak age of about 2 years, and you have the leukemias being between 1 to 9 years of age, and lymphomas being more than 10 years. So sometimes with the age, you know that certain tumors are more common with certain age groups. For gender, as stated earlier, we noticed that most of our cancers are commoner in males, but there are certain cancers in males. So we want to look at some of the genetic factors that account for susceptibility to cancers. So as I stated earlier, there are certain genes in our cells that regulate cell growth, and one such gene is the retinoblastoma gene. It's a tumor suppressor gene. So what it does in basic terms is that it prevents the growth of abnormal cells. But if there is a gene mutation in this cell, it's like a cell division police, so that it wouldn't allow the bad guys to go and multiply and increase. But when there is a mutation in this gene, then it's unable to do its function of policing the cell replication, where now, because it's not able to do its function, abnormal cells have their own way and they keep multiplying and their replication is unchecked. So if you have a mutation in this gene, then you are at risk of developing retinoblastoma, that's cancer of the eye bilaterally. Not only that, because it checks the replication of cells, it's not only retinoblastoma. These children, when they grow on to adolescenthood, are also predisposed to other cancers like osteosarcoma, that's cancer of the bone. Also, there are certain syndromes that are associated with cancers. So a child with trisomy 21, or what we call leukemia or retinoblastoma, if a child has neurofibromatosis type 1, she is also at risk of getting gliomas and malignant nerve sheath tumors. Also, if a child has a tuberous sclerosis syndrome, he's at risk of getting brain tumors. So these syndromes or diseases predispose you to getting cancers. Now we'll have a look at the environmental factors. So for the environmental factors, certain infections or microorganisms predisposed to certain cancers. HIV is associated with and also Kaposi sarcoma. So if a child with retroviral infection presents with generalized lymphadenopathy, you have to have the suspicion. All these are supposed to increase that suspicion so that we are able to pick up the cancers early. Also, Epstein-Barr virus, which causes mononuclear nasopharyngeal carcinoma. Also, where these children are exposed to high dose of cancers, and these radiation in turn also predispose them to developing other cancers like leukemias and also solid tumors like bone tumors, osteosarcoma. Also, certain chemical agents or drugs we use for treating cancers, that's chemotherapy, also predisposed to cancers. So the treatment of cancers in itself also is a risk factor to develop secondary cancers. Okay, so this slide is very important. It highlights the warning signs that are pointers for us to suspect malignancy in a child. So if you have a child with an unexplained weight loss, this child is losing weight and presents your facility, is eating very well, to expect that could it be a malignancy, a child with recurrent or persistent headaches, early morning vomiting. These point to raised ICP, which can be due to a brain abdominal distension or abdominal masses, swelling in the bone, joints, or legs. And sometimes these children may not present with an isolated symptom. The child may have persistent bone pain, this child may be pale, so there may be an interplay of more than one symptom. So you put the two together and suspect that this child may have a malignancy. Also, excessive bruising or bleeding or ecchymosis or purplish rash on the skin. Also, a child who is coming with recurrent infection. The child is managed on appropriate antibiotic and 3 weeks' time is coming with recurrent fevers or infection. We have to suspect that could it be a malignancy. Also, whitish discoloration of the pupil, what we call leukocoria, can be an early sign for retinoblastoma. retinoblastoma. So nausea, vomiting, constant tiredness or easy fatigability, any eye changes, eyes swelling, changes in vision. Also, a child presenting with recurrent present. If you're seeing a child consistently is being transfused, you've investigated it's not due to sickle cell, and this child is always coming to your facility pale, you have to ask yourself, why is this child always coming pale? Could it be a malignancy? Sometimes we just treat the symptom, transfuse blood, and the child goes home and comes back with anemia. You see a child who's constantly losing weight. We have to suspect so that we can investigate appropriately. So this picture is a child with leukocoria. That's the whitish discoloration of the pupil. Okay, this is a child who presented with a 3-month history of a jaw mass and with malalignment of the dentition. And this child had a biopsy done, which confirmed the Beckett's lymphoma of the jaw. This diagram is depicting petechiae. So sometimes in a dark skin, it's hard to tell, but you have these dark skin colorations or purplish colorations of the skin. And if you have some of these signs, you want to examine or you want to probe further. Could this child have a malignancy? Of course, there are other causes of petechiae. Could it be a platelet disorder, but could it also be a malignancy? Sometimes these are the pointers, the early signs we may pick up for malignancy in children. So the principles of evaluation, we know that for any patient, the key to making a good diagnosis is a detailed history and an appropriate physical examination. So with the history, you want to find out the onset. You know that cancers are usually insidious, so it's not a sudden onset, it takes a while. So these symptoms may be ongoing for some time. You want to find out any associated symptoms in the history. You also want to find out any, for the past history, has the child been diagnosed of any cancers before, undergone treatment, because you know that sometimes these treatments may predispose the child to it. Is this child having recurrence of the symptom or persistent symptom? With our examination, we want to examine the child fully. General examination, we're looking for swellings in the neck, in the axilla, in the groin. Is there hepatosplenomegaly? Is there any skin changes, which will point us to a suspicion of a malignancy? Then we'll move on to do our basic investigations, which include our full blood count, where it is very essential. We can pick up certain points, especially when the parameters are deranged. You have 2 or more parameters deranged. A child comes with severe anemia, thrombocytopenia, or you can have very elevated WBC, leukocytosis, or you may have suppressed cell lines. So you would have a neutropenia or pancytopenia. So that should prompt you to investigate, go on to do a blood film comment to look for any blast cells in the film comment. Also, you want to do some chemistries. You do your liver function test, renal function test. You do your uric acid and LDH to help you assess for the tumor burden. Radiologically, some investigations that may be done would include an ultrasound scan, especially if the child is presenting with abdominal distension or abdominal masses or a jaw mass, which you are suspecting could be a Beckett. You want to find out if there are also any intra-abdominal masses. You may do an X-ray. If based on the symptom the child is presenting with, you may even have to do a CT scan of the head, especially if he's presenting with CNS symptoms, persistent headaches, early morning vomiting. The child comes with weakness, any form of weakness or even seizures. In addition to these masses, you want to do a CT scan. Some definitive investigation would be bone marrow aspirate, especially from your initial investigation. If you are suspecting leukemia, you want to do a bone marrow aspirates to look at the marrow. You may also want to do, in cases of lymphoma, take a lymph node biopsy, or in solid tumors, you want to take a biopsy to ascertain the type of tumor that is present. In certain cases, some special tests are done, like immunophenotyping in leukemias, when you want to assess the prognosis, because certain phenotypes are associated with good or poor prognosis. For the treatment modalities, we have chemotherapy, surgery, radiation, some targeted drug therapy, immunotherapy, bone marrow transplantation, and other therapy like cryosurgery, laser therapy. But for our childhood cancers, most of our treatment modalities available to us here in Ghana, it's chemotherapy commonly, surgery, radiation therapy. So we just want to have a brief overview of the drugs we use in treating cancers. So these are cytotoxic drugs or agents that affect the rapidly dividing cells and cause these cells to die by interfering with the DNA replication and also the cell division. We must note that these cells, though they are targeted at causing cell death to these malignant cells, they also affect normal cells, because normal cells also undergo replication and division. So this diagram portrays some short-term side effects of the chemotherapy that is given. So you may have sore throat, what we call oral mucositis. So the children develop sores in their mouth, they lose, coming from their head down, they lose hair, because these cells also replicate rapidly, hair cells and skin cells. Side effects of the chemotherapy. This is important because, for most of our clients, when they receive the chemotherapy, they may be discharged, because not all of them would have to be on admission. So they will discharge and they'll be discharged and they'll go home. So they may present to your facilities with some of these signs that of the chemotherapy they have received. So, I was explaining that the chemotherapy also targets rapidly replicating or dividing cells, and some of the cells that divide rapidly, it's our hair, our nails, our mucous epithelium. So they have hair loss, they have oral mucositis, that's sores in the mouth, and therefore the child will typically present with difficulty swallowing. Yes. They could also have GI, vomiting, nausea, they can have diarrhea, or they could also come up with others in the bone marrow, like pancytopenia. As we stated earlier, most of our cell lines, blood cell lines are produced, or all of our blood cell lines are produced from the bone marrow. So some of these cytotoxic agents of chemotherapy suppresses the bone marrow. So you have reduced neutrophil counts, what we call neutropenia. You can have severe anemia and also thrombocytopenia because of the marrow suppression. You could also have others like neuropathy, where there's tingling sensation, hearing loss, amongst others. There are also some long-term complications, and these, when they are not well managed, result in mortality associated with cancer treatment. We realized that in our introduction, we noticed that most of our mortalities were due to complications of treatment, such as these. So for the long-term effects, they are usually associated with some specific cytotoxic agents. So we'll just look at a few in this table, where you can have neuropathy with vincristine. Methotrexate would cause mucositis. For cyclophosphamide, you can have hemorrhagic cystitis, where they present with lower abdominal pain and hematuria. For adriamycin, or what we commonly call doxorubicin, it to look at the state of the heart, so that if the ejection fraction is low, sometimes you even don't give the full dose. You have the percentage of therapy you are giving to such children because of the long-term side effects, because you don't want to cure the child. Okay. So these are some of the long-term effects of the chemotherapy that's given. Supportive care is very important because it also contributes significantly to our survival rate. As stated earlier, some of our children, by virtue of the drugs that they receive, would have immunosuppression and also suppression of their bone marrow. So they will be at risk of infections, bacterial or opportunistic infections, fungal infections, viral infections. So we have to be on the lookout. If a child with cancer is being managed and he started treatment and has reduced suppression evidenced by, let's say, neutropenia, and this child develops fever, that is not the time to okay, let's give paracetamol and see if the fever will come down. Already, you know that this child has neutropenia, the cell lines are down, so they cannot mount up any defense against infection. So you have to manage the infection aggressively. So you do your cultures and start antibiotic. Usually you want to start with a broad spectrum to cover both gram-negative, gram-positive. Also, in certain cases where the child is still has fever with neutropenia and is not responding to antibiotics, you have to consider opportunistic infections, fungal infection, viral infection, and start antivirals and antifungals. Usually for patients who have a neutrophil count of less than 500, will come to be noticed that they have severe neutropenia. So for them, they are started, in addition to their antibiotics, they are started on antifungals and antiviral, because we know that they are at increased risk. So we don't want to wait for them to get it before you intervene. Also, in these children, live vaccines are contraindicated as they have reduced immunity. So after a year, when chemotherapy is completed, these patients also need psychological counseling. So both parents and the child, you know, most of our children are adolescents too, because it's from 1 to 9 years. So you have to counsel the parents and the patient so that they understand the diagnosis, the treatment options available, and find out what their aim is, because you have to work with them for what they seek to achieve, what they are looking forward, bringing their child to the hospital. For some of them, the plan wouldn't be curative because they may come in the advanced stage. So you have to counsel them on palliative treatment and the options available. Another important topic we want to have a look at considering childhood cancers are the oncological emergencies, because you notice that most of our people in our region, when there's any swelling, they may manage it in the house. But when there's an emergency, if the child is pale, these are what will bring them to the hospital. A parent will notice the swelling and wouldn't be prompted to bring the child. But if the child is febrile, the child is pale, they will come to the hospital. So there are certain oncological emergencies that present to our facility, and that will be the point at which we may even get to diagnose these children. So it's important we take note of these, and when we see them at our facilities, after we've managed, we refer to the appropriate healthcare facility to investigate and subsequently treat if there is a malignancy. So we have tumor lysis syndrome, spinal cord compression, where there is a tumor compressing on the spine. So such children will present with paraparesis, they will present with urinary and stool incontinence. Yes, please. Hello?
Continue, doctor.
Okay. So there's also hyperleukocytosis, which we'll have a look in our subsequent slides. There's raised intracranial pressure. So you have a child who's been complaining of persistent headaches, but now comes with seizures. So the child would present with seizure. And from the history, you notice that there had been a history of persistent headaches or early morning vomiting, which is pointing to raised intracranial pressure. So that would prompt you that, okay, this raised ICP, could it be from a mass? Is it meningitis? Of course, we want to rule out the common things first, but you also want to find out if there's any history of weight loss. So sometimes these may not be the only symptom, but there'll be other symptoms that will point to a suspicion of a malignancy. Also, a child presenting in severe respiratory distress can be due to pneumonia, infection. It can also be due to superior vena cava syndrome in a child with malignancy. Then also a CVA, a child presenting with stroke, a child presenting with fever, and also neutropenia. You'd want to investigate for malignancy. So tumor lysis syndrome. Tumor lysis syndrome occurs when you have a massive tumor and the tumor starts to break down. It can be spontaneous, or it can be as a result of chemotherapy. Once you give the chemotherapy, then the cells start to break down. Or it can be the cells would break down spontaneously if it's a high or a large mass, like you have a large Burkitt lymphoma, or you have a child with a lot of blasts in the foot or the bone marrow aspirate. These children are at risk of tumor lysis. What happens is that these cells break down and releases the intracellular content. So once these cells break down, there's a release. When these cells lyse or break down, there's a release of potassium, phosphate, and nucleic acid into circulation. So this will lead to hyperkalemia, hyperphosphatemia, with associated hypocalcemia. And these nucleic acids are broken down to uric acid, and these result in hyperuricemia, which, if it's not well managed, can lead to acute kidney injury, because this uric acid will form crystals that are deposited in the renal tubule and also deposited in the renal vasculature, reducing perfusion, reducing glomerular filtration, and resulting in an AKI. So this has to be managed immediately and appropriately. So for tumor lysis syndrome, most of the time is anticipated if you don't wait for it to occur. So there's a preventive arm where you have a child who is presenting with, let's say, hyperleukocytosis or a lot of blasts, a lot of tumor cells in the blood, or for solid tumors, there is a large tumor. So you have this huge jaw mass. You know that when you start chemo, or these huge jaw mass, by virtue of its size, can break down and release a lot of these phosphates, hyperkalemia, resulting in arrhythmias and even cardiac arrest. So once these children present, you want to start hyperhydration, give allopurinol or a urate oxidase. What allopurinol does is that it prevents the formation of uric acid. So this nucleic acid, they are converted to uric acid by the xanthine oxidase. So allopurinol would inhibit this enzyme. So it would reduce the synthesis of uric acid. But sometimes you have a child will come and you do the uric acid, which is already elevated. With that, allopurinol would have little effect on the already elevated the uric acid. So you'd rather prefer a urate oxidase, that's the rasburicase. What it does is that it metabolizes the uric acid into a soluble substrate, which is the allantoin. That is water soluble, so it can easily be excreted. So that's the difference between allopurinol and the urate oxidase. All of it is used in the management of hyperuricemia, but allopurinol is limited in its function that it rather prevents the formation of uric acid. So if you already have a lot of uric acid, it will just prevent further formation, but you have to mop up the already accumulated uric acid. So in that case, you would rather use a urate oxidase. So for the treatment, you manage the elevated ion. So for phosphate, you want to give aluminum hydroxide to aid excretion of phosphate from the body. For hyperkalemia, you want to manage. So initially, you want to give your calcium carbonate to stabilize the heart, then nebulize with salbutamol, which will drive this elevated potassium in the blood into the cells. So you do a back-to-back nebulization every 30 minutes for 2 hours. Then you repeat the electrolytes. Sometimes it's corrected, other times you may have to repeat it. And of course, there are other forms of management where you use insulin and dextrose to also drive the cells into, to drive potassium into the cells, or you may use potassium chelating agents like carzelate. In certain cases, when you have hyperkalemia, hyperphosphatemia with reduced urine production or anuria, that you have an AKI, so you are not excreting any of these substances, there's an indication for dialysis where you take out these substances from the blood. So when you have a progressive renal failure with hyperkalemia, hyperphosphatemia, anuria, that's an indication for dialysis. Another complication that may arise from childhood cancer is hyperleukocytosis. And this is seen in children with acute lymphocytic leukemia or myeloblastic leukemia, where you have a WBC count of more than 100,000. What happens is that in children with hyperleukocytosis, when you have a lot of these cancer cells or leukemic blasts in the bloodstream, there is increased viscosity causing stasis. So these cells, they have a high tendency to attract themselves to each other. So they come together, making your reducing blood flow, what we call sludging, because of the increased viscosity. And therefore, what it does is that it stimulates production of cytokines, which are inflammatory markers, which in turn would reduce perfusion, because these inflammatory markers would stimulate vasoconstriction. So aside the fact that there's viscosity and reduced flow of blood in these vessels, there's also vasoconstriction, and all these will lead to poor tissue perfusion. So you have hypoxia, which can occur in the brain, in the lungs, other parts of the body. And these lead to these manifestations. So in the CNS, you can have dizziness, you can have tinnitus, you can have gait instability or visual changes. You can even throw an embolus and have a CVA from leukostasis. Also, for the renal system, you can have hypoxia from reduced tissue perfusion. You can have tachypnea, dyspnea. For the genitourinary system, you can have poor renal perfusion leading to an AKI. So you can have oliguria, anuria. And also you can have priapism when these stasis cause thrombus to form in the vessels in the penis. You have priapism, that's painful erection. For the treatment of hyperleukocytosis, you want to increase blood flow, and therefore you want to increase oxygenation at the tissue level. So you want to give high doses of IV fluids, preferably normal saline. So we give it at 3 liters per meter square. You also want to give allopurinol. Remember, we said that when you have a lot of these leukemic or blood cells in the blood, they'll break down. And when they break down, they are releasing potassium phosphate and also uric acid, which can also get deposited in the renal tubules and cause an AKI. So you also want to give allopurinol to prevent that from happening. Also, with hyperleukocytosis, you may transfuse platelets when it's less than 20, because you also want to reduce the risk of intracranial hemorrhage, which can occur when there is stasis. There's active use of the coagulating factors. So you are predisposed to bleeding. So if the platelets are also low, then your risk of intracranial hemorrhage is further increased. Also, for such patients, you are not quick to transfuse because already they have a lot of cells in their blood, which is causing viscosity. So if you are going to transfuse and give blood, you are increasing the amount of cells, which will worsen the viscosity. So if the child is not symptomatic or the HB is not less than 6, you don't transfuse in a child who has a WBC count of more than 100, which is hyperleukocytosis. So you only transfuse if the child is symptomatic. And in that case, you would actually even prefer whole blood to packed cells, as packed cells would worsen it. In this case, our aim is to reduce the tumor cells or the blood cells, leukemic blood cells. So you also want to start your induction or start chemotherapy. So for acute leukemias, we start the steroid prephase. For those with myeloid leukemia, hydroxyurea is started. And the point is that you want to start chemotherapy early so that you reduce the cancer cells in the blood. Another oncological emergency we may have a patient presenting with is febrile neutropenia. And this can be as a result of the underlying malignancy. We said that most of these blood cancers or leukemia, there's suppressed bone marrow. So there's reduced neutrophil counts, there's reduced platelets, there's reduced HB. So in a child who has reduced neutrophil count, what's neutropenia, when the absolute count is less than 1,005, and also have fever, temperature more than 37.5 on 2 occasions, 30 minutes apart, or if you do it at one time and the temperature is more than 38.3 in a child who has neutropenia, it could be due to a tumor or a malignancy. So you'd want to assess this child. And these are some of the complications that may lead to mortality if they are not identified and managed. So in such a case, you want to do a septic screen for this child. So your full blood count will show that the child has neutropenia, and that is graded. Usually mild neutropenia is 1,000 to 1,005. If you have less than 1,000 to 500 is moderate. And severe neutropenia is less than 500. And these, at less than 500, these where you want to also, in addition to your antibiotics, also want to cover for fungal and viral infections. So you put them on fluconazole, you put them on acyclovir to also cover because they have severe neutropenia. And less than 100 is profound neutropenia. So if a child presents to you with fever as stated, and you do a full blood count, the neutrophil count is markedly reduced such that the child is neutropenic. We also want to suspect febrile neutropenia. And in this case, it's not like any child who comes with fever and neutropenia is automatically febrile neutropenia. It's a diagnosis of exclusion. So you have to rule out other causes. I mean, it can be due to infection, it can be due to other causes. But typically when you have reduced neutrophil count, probably with another reduced parameter like a bicytopenia or pancytopenia. So you have reduced platelet count, you have reduced HB and neutropenia with fever. You also want to consider febrile neutropenia, which is the complication of cancer. Usually the blood cancers, leukemia. So with management, you want to, as I stated earlier, do a septic screen, blood cultures. If you can't do these, the best you can do is to at least start antibiotic and refer to a facility where they can be managed, do a septic screen, then start broad spectrum. So there's not the time to be stingy with antibiotic. You have to make sure you give a broad spectrum, something that will cover for both gram-positive and gram-negative. So preferably ceftriaxone with gentamicin or Cipro with flucloxacillin, so that you cover both gram-positive and gram-negative. Sometimes we go as high as the 4th generation cephalosporin like cefepime or meropenem. So one aspect to this febrile neutropenia is to prevent infection. A child may have neutropenia and not necessarily have fever. So for our neutropenic patients, due to the underlying malignancy or even as a result of the chemotherapy that has been given, you want to ensure infection precaution so that we limit their exposure to microorganisms. So such children who are neutropenic would have to be isolated from the very sick child. So you don't put a child with severe neutropenia next to a child with, let's say, pulmonary tuberculosis or a child with a very bad Staph aureus sepsis, because then you know that this child has all her defenses down, so she's more at risk of infection. So you want to, if possible, isolate them. But we know that sometimes with our facility, there's not enough bed, let alone to just create a space or a room for our patient. But what we can do is that we can actually screen the child, advise the parent, the guardian, and the child, himself or herself, to observe infection prevention. So the washing of hands, the child has to bath so that regularly twice a day, or the mother has to clean the child. We don't want to expose the child to death or infection or microorganisms. We also want to encourage good oral hygiene. So the child should use an antiseptic, maybe Camaclos, to clean the mouth twice daily. You also want to continually inspect the various sites that can predispose to infection. So the cannula site, you want to inspect, is there any reddening? Is there any change in color, or is it contaminated? Maybe sometimes you see the plaster that has been used to secure the cannula is very dirty, you want to change it. Also, you don't want to do rectal procedures in these children because these can easily break the mucosal surface, and these organisms in feces can easily translocate to the blood and cause infection. So for children with severe neutropenia, you don't want to be doing DREs for them or giving suppository medication. So that is not the time to be given paracetamol suppository for their fevers. You can do oral or even via IVs. Also, you want to prevent constipation in these patients because the more the stools stay there for a long time, then there's proliferation of these guts bacteria and microorganisms that can easily translocate into the blood and cause infection. So you also want to prevent constipation in these patients, and also want to ensure that appropriate antimicrobials are given. So they are getting the appropriate antibiotic, the doses are right, they are being covered for those with severe neutropenia, they are being covered for both viral and fungal infection. And once these are done, it's important that you refer the child to a facility where investigations can be done to diagnose cancer, and they will get the appropriate treatment early. So you don't manage the child and discharge home when you have some of these presentation. So in summary, our take-home message is that for optimal cancer treatment, we have to have a high level of suspicion. They are uncommon, so it's very easy to miss. And they present with signs and symptoms that can be any infection or can be any disease, fever, weight loss. So you have to have a high index of suspicion, take very good history, and refer appropriately to the pediatric oncologist so that treatment can be started early and these children will have a better chance at survival. Also, early detection and treatment is very important because that will reduce the disease-related mortality. If they are detected early, then we'll have a better chance of cure, not just palliative where they come with very advanced disease spread to all over the body, and our aim is now to just palliate, make them comfortable. Also, we have to take note of the warning signs. So if you have a child presenting with unexplained fever, unexplained weight loss, persistent bone pain or headaches, easy fatigability, easy bleeding, or a child who has these gum bleed or petechia bleeding into the skin, or a child with any eye change, whether it's a leukoria, is swelling of the eyes, or visual impairment, you want to investigate further, take a detailed history to find out if this child is at risk of cancer based on the presentation, and refer appropriately so that they get the optimum care and have a better chance at survival. So I'll bring my presentation to an end here and invite questions. I think it's going to go off. So once we log in, if there are any questions.
Thank you very much, Dr. Emma. God bless you so much. God bless you. I believe this has been a very great presentation. I love it so much. And I believe people have questions to ask. There are a lot of things that you've opened it up to us, and me, myself, have some questions to ask. But since we have just a few minutes, we will continue with the questions, and I will encourage all of us to try our best and rejoin when it goes off so that we will continue with the questions and answers. So, Doctor, God bless you. God bless you once again. God bless you once again. I'm so happy. I'm so happy. But I'll be glad if you'll be able to put another summary on the prevention, because all that you've done along the way, I was becoming afraid. Because looking at the things that the child will go through and some of the things, I think is too much. So is there any made? Fine, we know some of the things are idiopathic. We don't know the cause. But you mentioned some environmental factors and all these things that I believe we can put some things together so that we will not get to the door of this childhood cancer at all. So I'll be glad if you can put in summary some of the things that we can do so that we will not even come near this childhood cancer at all, so that we will focus much on that. But in case the idiopathic part comes in and we have to battle with these issues, then we will console ourselves and walk through it.
It's a bit of a challenge to prevent, because sometimes these radiations, of course, you want to limit yourself to these radiation, let's say a high, maybe you're living around these high tensions, they emit some radiation, but you know, these radiation therapy are very high doses that's predisposed to cancer. So for the environmental factors, what we can prevent is that usually for pregnant women, we would advise that, you don't take in, once you are pregnant or you're on chemotherapy, it's stopped. You take contraception whilst you're on your chemotherapy so that after a year, after your completion of your chemotherapy, you can now have a child, because when you are pregnant and you take these cytotoxic, you predispose your fetus to these cancers. Also, you want to limit these pesticides. These are some of the things you can control for the environmental factors. Some of these pesticides have lead and all that. So once you're handling them, you want to make sure that you are appropriately dressed. So you have your hand, especially farmers or those who use some of these pesticides on their farm, you make sure that you have your nose masks, you have your hand goggles, so that in mixing them, you don't expose yourself to these chemicals. So these are some of the things that we can do to prevent it, but I'll add a slide and probably before giving out the slide to highlight on them. But for childhood cancers, the key is early diagnosis. So the stress for this whole presentation is the warning signs, because for outside, some cancers, they achieve as high survival rates as over 90%. But in Ghana, we are still hovering less than 30% because they always come in late. So if we are able to get them at the early stages, it would really help with our survival rate.
That's great. Thank you. Thank you very much. Thank you very much. I think we have 2 minutes and the thing will go off and you'll rejoin. But before I'll go to my next question and you will allow other people also to come in. You mentioned of the high tension. Is it the one like MTN, Pulse, Vodafone Pulse? Is that those ones you're talking about?
No. So, you know that we have certain radiation points, like even if you know, we have nuclear plants around, and those places, they actually don't allow people to build around it. But you know how sometimes we want to build anywhere. So those nuclear points or high tension points. So it's not really like the MTN portion, because these emits radiations, but research hasn't been done to see if these radiations can amount to cancer. So in effect, you don't want to be a scapegoat to be used. So you want to avoid all these places with equipment that emit radiation. And that is why even in children, for some of them, if an MRI can be done or like it's affordable, we prefer that to CT scans, because that also has more radiation as compared to MRI or even a chest X-ray.
Wow, thank you very much. We have less than 1 minute, so it's possible we'll be going off any moment from now. But please, is all this treatment, management and all, is it for free, or are they under national health insurance, or the client is to bear all the costs?
Okay, so this is a very difficult question. So this treatment is not for free and it's not under insurance. But lucky for us, God being so good, there are certain stakeholders who are always raising funds. We have some of these Rotary clubs and stakeholders, and also our partners like the Cancer Society and Pediatric. As I was saying, let's take an example like leukemia. So with their induction, when we start the treatment, there are some medication, vendoxosteroid, those are available. So because of donations from our sister hospitals outside, these are free, but a drug like asparaginase, they will have to buy. And for a typical induction phase, that will cost the parent about 3,500. And this is dependent on the body surface area for the child, because that's how the chemotherapy drugs are calculated. So these drugs are not under insurance. We get some people donating, and there are certain institutions that are set up. Recently, PZ has a collaboration with one of the Rotary clubs. So if you have a child with cancer who can't afford the investigation or treatment, you refer to them and they would judge each case and make funds available. So now money shouldn't be a reason for not referring. Even if they don't have money, you can still refer and would apply to these foundations. PZ has set up a cancer fund, cancer treatment foundation, where you can apply for your patients and get funds.
Okay, thank you very much. Oh, doctor, you can still mute those who are yeah. Okay.
Okay.
Please, I think we are now opening the floor for those who have other questions to ask. So if you have any question, you can unmute yourself and you will call and you ask. If you want to write it as well, you can do that. You can write it, you read for doctor to answer. Thank you very much.
Okay, please, I have one question.
Yeah, please go ahead.
Okay.
Yes, I don't know, probably I left that part or something. I want to find out. I didn't see anything about genetic predisposition as far as pediatric cancers is concerned. I didn't see anything about that.
Okay, so I talked about it, but I can just easily recap. I said that for pediatric cancers, usually for most of them, the cause is not known, but there are certain genetic susceptibility and environmental factors at play that increase your risk of developing cancer. So for the genetic factors, I use one gene mutation like retinoblastoma gene. So it's a gene that regulates cell division or replication of abnormal cells. So if you have let me just share the slide. If you have a cell replicating that has undergone a mutation, so it's now abnormal, in the process of DNA formation, there has been some errors that weren't repaired, then this retinoblastoma gene will prevent these abnormal cells or these impaired cells from going on to divide. But if you have a mutation in the retinoblastoma gene, which, or if without any mutation, is acting more or less like a cell police to prevent division of abnormal cells. If you have a mutation in that gene, then now all these abnormal cells or cancer cells or these cells that have undergone mutation can replicate, and this is what will predispose a person to cancer. So such people, when you have a mutation in that retinoblastoma gene, you're at risk of getting retinoblastoma. Not only that, in adulthood or in adolescenthood, those children go on to get other cancers like osteosarcoma. So genetics is at play in the course of childhood.
Okay, thank you very much.
You're welcome, Ernest.
Thank you. Please, the other participants, any question?
I think Ruth's hand is raised. So Ruth, you can unmute yourself and ask your question. Hello, Ruth.
Hello.
I have to unmute her.
I think she has unmuted herself, so we are waiting for her to talk. Sister Ruth, can we hear you? Okay, if she's not ready, is anyone also asking a question? Okay, doctor, as we wait for others to come in, can you check under the clinical presentation when you were talking about the GYAWU, you were mentioning some things and I saw priapism. And
Yeah.
the priapism, is it also found in the children, or this time you are looking at a general view of, I don't know.
No. Priapism is found in children. Even for our children with sickle cell disease is one of the complications they come with.
Okay.
So they have painful erection. Yes. So it's not adults. Everything I'm saying is in regards to pediatrics, so in children. And that came as a complication of the leukocytosis, hyperleukocytosis, where they have a lot of cancer cells in the blood, causing increased viscosity stasis. So these kind of clog your vessels. So there's no backflow of the blood when it fills the penile vessels to cause the engorgement. So they have painful erection, which is priapism. So it's in children, the same way we have the priapism in sickle cell disease. When the sickle cells prevent blood flow.
Okay.
So it's in children.
Thank you very much. Please, Sister Ruth, will you now ask your question? Hello, Sister Ruth.
Hello, can you hear me now? Can you hear
Yes,
me?
we can hear you.
Hello.
Ahead.
Okay, thank you very much. Okay. Nasu joining from Nigeria. Thank you, Dr. Emma. Thank you for this lecture. Network has been very bad from my end. I noticed when you were presenting the side effects of the chemotherapy, something caught my attention, and that's the contraceptive and fertility effects of the contraceptive.
Okay.
Since we are discussing about childhood cancer, are we talking about these children?
Yes.
Or are we talking about chemotherapy in general?
So, when we talk about pediatrics, it's usually from birth to 19. And you admit that our adolescents, 19 years, can be sexually active. So if you have an adolescent who is undergoing chemotherapy, you want to do contraception for them so that they don't get pregnant during that phase. So that is for our adolescent population.
Okay.
Yeah.
If I understood that, that means they have high fertility while undergoing chemotherapy.
No,
or
so
they are not advised to
they
get
are not
pregnant.
advised to get pregnant. We want to prevent pregnancy for our adolescents who are undergoing chemotherapy. Because normal, the fetus predisposed to cancers or even some abnormal malformations. That's why they have to wait a year before they start. If they want to have children, they can go ahead. So that's for our adolescents.
Thank you very much.
Thank you very much, Doctor. There is a question in the box.
Provider here in Nigeria, this means that goes hormonal contraceptive has effect or predisposes someone to cancer. How is true? Can you please shed light on that?
Okay. So we know that contraception can predispose to certain cancers, especially for our women, endometrial cancer. Yes, so those are for adults. But all these, you have to put in context, especially for how long, because some contraception, for some cancers, contraception is also protective, because the whole cycle of your endometrial lining proliferation, those cycle up and down cell changes can predispose you to get cancer. So for some particular cancers, the contraception will be protective, because once you are not menstruating and having all these hormonal imbalances, you are protected. But for some gynecological cancers too, contraception is a risk factor. Hello,
Thank
Ruth.
you very much.
Yes, please.
Yes, I'm here. Thank you very much. I got that.
Okay. Yes.
Okay, you're welcome, Sister Ruth. Thank you very much for joining all the way from Nigeria. We love you so much. God bless you. Sister, Doctor, please, there is a question in the box, but that is, please, can children living in an environment where there are masks installed have effect on them? I'm actually not getting that mask from Sister Matilda Crystal.
Okay, so Matilda, if you can unmute yourself, do you mean mask installation as in, is it?
I think she means the telecommunication network mass. Yes.
Yeah,
Okay.
So as I said earlier, these telecommunication emit radiation, but it's not to that capacity to cause cancer. We are talking about, when we talk about this radiation, we are talking about high dose of it.